Welcome to Fuller Butz, a behind-the-scenes plastic surgery podcast. Yes, you heard that right. Join your co-hosts, Dr. Sam Fuller and Dr. Dan Butz, board-certified plastic and reconstructive surgeons, on an exclusive full-access pass into the world of plastic surgery. Combining their expertise and training, Doctors Fuller and Butz will share medical insights, detailed explanations, and lighthearted humor to keep you entertained and informed. We're certain you'll become passionate about the plastic surgery specialty, and between debunking myths, uncovering truths, or just making you laugh out loud at their perspective on this creative and artistic field, we've got something for everyone. From tummy tucks to Botox and mommy makeovers to surgery do-overs, the Fuller Butz Podcast will surely satisfy your podcast fix. All right, now let's dive into this episode.
Hello and welcome back to the Fuller Butz Podcast. Joining me, as always, is Dr. Dan Butz. I am Dr. Sam Fuller. We are two board-certified plastic surgeons discussing all things plastic surgery, and we have a great episode for everyone listening today. Dan, how are you doing? Where have you been?
Yeah, it's been a while. I grew a beard, then I cut it off. Winter's been cold, and now it's warm again. It's been just a busy time of year. What's new with you?
Yeah, we've been busy cases. Most patients really like to have these sorts of plastic surgery, the mommy makeover, tummy tuck, when it's cold out, when they can sort of relax and be cozy. Maybe they're not as active in time for it to heal, recover, and to show it off come summertime. So we've been busy doing a little bit of remodeling to the house, lost some internet, and my studio went down for a little bit. So we took a mid-season hiatus, but we're back with a vengeance, ready to excite, educate, explore plastic surgery.
Yeah. So those summer bodies are made in the winter, right? So I think we're going to focus on one increasingly popular surgery, breast reductions today, correct?
Yeah. And, it really came from just the amount of volume of breast reduction cases that we're doing, talking about different techniques, and just realized that we haven't discussed it yet. And we're almost end of the season 2. And for a very common procedure, glancing over it and glossing over it, I think it really requires its own episode. So why don't we dive in with that? Breast reduction surgery. Dr. Butz, who is a candidate for a breast reduction?
Really, anyone who's healthy and wants their breast to be smaller. There's certain, criteria that people often talk about. Someone who has really large pendulous breasts, meaning they're hanging, pulling, and causing neck, shoulder discomfort, bra grooving, rashes underneath the breast. Those are some of the classical symptoms that are described with it and that the insurance companies like to see. But more and more I'm seeing patients who are just like want this more petite ballerina body, kind of petite breast, don't want to have to rely on as much supportive bras anymore. So it's not, they can be a smaller or a larger kind of reduction depending on what they're looking for. What do you talk to patients about, kind of what are their goals frequently when you see patients looking for reductions in terms of, is it just about how it looks or lifestyle?
I mean, this is among the most satisfied patients that we see. They're happy, and I think they're happy for a number of reasons. Functionally, quite literally, they feel like weight is lifted off of their chest, their shoulders, their back, even in the recovery room where they're coming back just feeling taller, wider, narrower. So I think taller, narrower, not wider. And so functionally, I think that there's great benefits. They're just not having this weight that's hanging. And then I think aesthetically, it can also be a huge transformation. And so I talk with them just about their goals. Are their expectations realistic? Do they need a breast reduction? Sometimes when patients feel like they want a lift versus a breast reduction and they want to actually have more volume in the upper pole, we talk about an augmentation, mastopexy. We're actually adding volume, but for patients who have a lot of volume already, a breast reduction is really a go-to. And Dan, that one thing that you said as far as women really pushing for a breast reduction just because of the social trends and whether it's ballerina body or what have you, I think that limits some of the insurance basis versus cosmetic basis. So do you want to dive into, or maybe we can both explore together, a common question that my office gets, I'm sure your questions gets, is, will my breast reduction be covered under insurance, or is this an insurance-based or cosmetic case, and we can maybe both give our 2 cents. Why don't you go first?
Yeah, so every insurance company has like kind of different criteria, but oftentimes they want to see those functional issues we talked about well documented and that have not resolved with non-surgical treatment. So have you done PT for 3 months? Have you tried multiple sports bras? Have you tried topical therapy for the rashes? And you also need to kind of hit a threshold of volume per your body surface area. So there's this little sure scale, I think it's called, that based on your height and weight, you need to have a certain amount of breast tissue removed to get it covered. So it's kind of argument, or what's the word I'm looking for? Difficult to kind of get it approved, arduous, depending on. Yes, thank you. If you fit all those criteria. We don't work with insurance companies just because they make you jump through a lot of hoops, but a lot of patients do ask that question, and sometimes we'll try to get that documentation and submit it themselves. Did I miss anything? What else is on there?
No, I mean, just to be clear, my office does not accept insurance as a breast reduction pathway, just for the things that you mentioned. It's extremely arduous. We're forcing them to do therapy, to really trial multiple bras, weight loss, medications, all for the insurance company still to say no. And then when you're limited by the number of grams or weight that you need to have removed, that's I would say anxiety provoking to a patient who maybe doesn't want to have that much off, and to a surgeon who maybe doesn't feel like that's the right amount to remove. And so by going the cosmetic route, really the surgeon, the patient can optimize their goals for what they're removing and not feel like they're spending extra time and money doing tasks that really aren't going to solve the issue to the degree that the insurance companies may like. And I think it's really just a weeding out period where, okay, like we really don't want to pay for it. We're going to make them jump through all these hoops, and hopefully they lose track of the goal line. I just did a breast reduction today. Actually took off 1.4 pounds on the left side, 1.7 pounds on the right side. And it's just a wonderful thing, especially when you do one side and then you're looking at it halfway through the case versus the other. Like, wow, this, you can't help but feel good about what those results are going to deliver.
Yeah, it can really transform the person's entire proportions, right? They often come in looking top heavy, wearing baggy clothing to almost hide their breast, requiring pretty elaborate bras to support things. And like you mentioned, they right away they can stand up straighter and they just look leaner or thinner, lighter, and literally are lighter. So it's a very popular procedure for all those reasons.
So as far as the consultation process, like with the patients in your office, what are some key questions? What are some key physical exam findings that you are evaluating in order to determine the surgical recommendations for a patient?
Yeah, so we start, with a pre-op, history and physical, kind of just general information about them, their medical history, make sure they're a good candidate overall, which most patients coming in are. And then finding out what their goals are, what their current bra size is, what they're kind of shooting for. If they have wish pics, something that's helpful to see that, and kind of talking about realistic expectations. If you're a J or H, it can be hard to get you down to a B cup, and bra sizes are so variable. We talk a lot about that. And then obviously during the exam, we take a lot of measurements, the notch the nipple, how far down are the nipples, the width of the breast, nipple to fold. And that kind of helps us with the planning of the procedure. And you look at different asymmetries, then kind of trying to show them what we might be able to achieve if they want it bigger or smaller, some of those nuances. Some people ask me, I use 3D simulation for breast augmentations. I don't find it to be as accurate for reductions in the lifts only, so I don't tend to use it for those because it just kind of creates almost more confusion, just because it kind of over promises and you can do anything on a computer. So a little more limitations with that. Do you do anything differently?
No, it's important, especially for women over 40, to make sure they have an updated mammogram within the last 12 months, discuss personal family history of breast cancers, any abnormalities as far as their exam would want to point out, and really going over the asymmetries, as we've joked about. episode after episode. The breasts are sisters, not twins. We need to point that out. And we're trying to make them as symmetric as possible, but there's no, true human who's identically a mirror image of the other side. Discussing with the sizing and the goals, what I'll typically do is in front of the mirror, simulate the reduction, the lift, just by pinching skin, pulling up, just to give them a sense of where the breast tissue is going to be, where the scars are going to be, and then, kind of try to give a realistic expectation that this isn't an augmentation. The upper pole fullness is not going to be voluminous, and gravity always wins, just so that they're aware of that. But oftentimes that's not a deal breaker. They're excited to have the breasts where they're properly positioned. And speaking of which, a nipple is a huge topic of discussion. Even, today was joking with the patient and her family member about the nipples, because that seems to be a big mystique or mysterious thing. Dan, what do we do with the nipples? Or if the patient asks you, as they asked me today, do you just take it off and put it on the back table for a little bit and then just like staple it back on? Or what are we doing with the nipples for breast reductions currently? That's
such a common question. I feel like frequently at 3 weeks I'm taking off the tape. I'm like, oh, my nipple doesn't fall off. I'm like, it's not going to fall off. So, there's a lot of different varieties of techniques for how to do a breast reduction, which might be getting a little bit into the weeds, but typically we're leaving the nipple based on a pedicle of breast tissue. So that pedicle has a blood supply, a neurovascular supply, so you can still maintain sensation. And if you're younger, likely the ability to breastfeed, which we'll touch on in a minute. But then we're leaving that kind of base of volume and removing all the breast tissue around it. And then the skin, removing the excess skin and then wrapping things around and getting it more lifted and supported. So we utilize these cookie cutter devices that are perfectly circular. There's different sizes, so depending on breast size and what our goals are. Typically I'll use anywhere between a 38 and a 42 millimeter nipple diameter to mark things. And that kind of marks reduces the baseline areola for most patients. It's often a common question: are you reducing the areola? And then when we're insetting the new position, making the same diameter for that. But it's a frequently source of anxiety of what happens to the nipple, how you do that, and is it going to fall off, which it isn't. But if you want to touch on that, there is a technique, and maybe that's where the confusion comes from. Free nipple technique, and when and if would you ever use that, Sam?
Yeah, it's been a long time since that's been instituted in my practice, and I think with the current and better thinking of anatomy, blood supply, oftentimes that can be avoided or never really used. But as we've said before, plastic surgery is the constant battle between beauty and blood supply. And so, why we would need to remove the nipple and sew it back on is if the distance or the blood supply to the tissue that's left behind is inadequate, it's inadequately perfused, then that's going to not survive the reduction. And by knowing where the blood supply can come from to the breast, you can choose your pedicle or the basis for the blood supply to that area. In extreme cases, in extreme ptosis or reductions where you're removing pounds and pounds of tissue, or the nipples or the breast tissue is being folded in your waistband and you're exceeding 40, 45, 50 centimeters from the sternal notch, those could be situations where a free nipple graft is performed. And that's actually using a scalpel, very carefully, delicately removing the nipple from the breast, setting it aside, reconstructing the breast mound, and then securing that to the center point of the breast mound. That nipple is alive, it's living, its blood supply has to grow back into the underlying tissue. It has been probably 7 or 8 years since I've needed to do that. And the last case was I removed 9 pounds of breast tissue per side. 18 pounds of breast tissue removed, where there was no way I was going to be able to maintain the blood supply to the nipple. And so a free graft of the nipple was performed. That obviously does not allow for nipple sensation afterwards. So the reason why we want to keep it, besides being less work and easier to recover from, fewer dressing changes and wound care, is that oftentimes we are allowing nipple sensation to stay the same. I usually quote about 75% of the time, nipple sensation is the same, 12.5%, and maybe increase, 12.5%, maybe decrease. What numbers are you floating to patients, or are you basing it on?
Yeah, I mean, nipple sensation loss, I think, is quite rare. I'm sure there's been a couple, but I'd probably say less than 5%. for reduction lifts alone. And yeah, oftentimes it's more sensitive. You get the weight of the breast tissue pulling on those nerves, and it often improves. But most of the time, just the same. So probably a 75% normal, 15%, a little bit increased, and then maybe a little altered for 10%.
So where are the scars going to be?
Most commonly we're using what we call a WISE pattern, which kind of leaves you with that traditional kind of anchor incision people talk about, where it's around the nipple, that vertical incision straight down, then along the fold. And that crease incision, typically isn't all that visible. It kind of hides in the shadow a little bit and doesn't go all the way to the center. Depending on if you have like more laxity on the side, sometimes it does go a little bit further lateral to kind of try to get that skin smooth. There are other modalities. Sometimes people try to really force a kind of a more just vertical approach, which sometimes you get some bunching, which, people talk about it kind of stretching out over time. But I tend to prefer that, more anchor incision. And the lollipop or the circumareolar or just around the nipple tends to be pretty limited in how much reduction you can truly do, unless it's a really small one. And there are liposuction techniques. Have you ever done that where you just liposuction the breast to reduce it?
I have not done liposuction only, but to me, it's been a great supplement and additive to certain cases where either it's a more minor reduction or lift, and they have this extra fatty breast tissue mound that's in that pre-axillary or just above the armpit, or even extending into the armpit, that breast tail. We can really improve the contours of the breast by going where we're not surgically going to be going. But as far as just doing a liposuction only, to me, that would be challenging.
It needs to be a unicorn patient, right? They need to have like really good skin, like not really any ptosis, and really soft, fatty breast tissue. A lot of times you have really dense breast tissue. You can't liposuction that. So I remember learning about that in residency, but I don't think I've ever actually seen it performed. But yeah, it's a great adjunct for shaping the lateral chest, that bra line roll, kind of up top. So definitely utilized in almost every breast reduction.
Yeah, I think it's important. Just every action has a reaction. So there's pros and cons to everything. So while patients may say, oh, wow, let's limit the amount of scar. Let's just have it around the nipple and pull it all together. That has a high chance of stretching, of being, very wide and thickened just because all the tension that's there. And so by, just having the surgeon choose a technique that they're comfortable with to get reliable, consistent results, I think ultimately is the best. Although the upside down T or anchor incision seems to have a lot of scar or incision, it tends to be well concealed and hidden in the creases, and allow you to almost work as a tripod and reposition that breast more superiorly and provide the projection that it needs.
Yeah, and that vertical incision really allows you to narrow the breast. A lot of just around the nipple, and there's some other Goldilocks incisions, things like that, which doesn't allow you to narrow the breast, which frequently these breasts are quite large or wide. And the scars do fade. I mean, it's pretty remarkable. You see a patient back at 2 years, and it's just a faint white line for the vast majority of patients. Are there anything you do to kind of try to optimize scarring? Aquaphor, perhaps?
So I've transitioned to use Aquaphor a lot more. Truth be told, after our discussions, the recovery, I feel like it begins in the operating room, and so part of the technique I have now is they get perioperative TXA or medications that help reduce bleeding, inflammation. I actually use an Arista powder, which is a sort of natural vegetable-based hemostatic agent.
Isn't it?
Yeah, and it smells really good.
Yeah.
But it's just a powder, and it allows us to just decrease the risk of having fluid volume build up, because when you're removing that amount of tissue, there's a lot of empty space that's there. For larger cases, I still use drains. For smaller cases, smaller reductions, which is a case-by-case basis, I don't use drains for breast reductions, but I think in the very large ones that we do see, sometimes they can be helpful. So it starts right off the bat for trying to decrease inflammation, swelling, pressure on the incisions. My otherwise post-op protocol is the Steri-Strips are on for about 3 weeks, 2 to 3 weeks. I switched to Aquaphor for 2 weeks or so. And then starting between 4 to 6 weeks is when we allow for silicone gel sheets along the incisions, silicone gel or vitamin E ointment around the nipple, and allow that to improve the scarring for the first 2 to 3 months. So those scar healing can last 1 to 2 years. How about you?
Yeah, very similar. I haven't used drains. in a long time. But yeah, sometimes for the larger breasts, it just swell more. Probably doesn't hurt to use those occasionally. But yeah, same kind of tape process. I think that seems to work really well, protecting it, keeping the tension off of things. It's just a process and time. That time is the biggest thing for scarring, in my opinion. But all those things can help, but you just got to be really religious about it.
I was just going to ask, when do you tell patients to expect final results? Like when is the breast going to look like you want it to look like?
Yeah, I mean, final results probably 6 to 9 months, but scars up to 2 years. Normally things look pretty much like they're going to look probably by around 2 to 3 months, but just subtle stuff after that. But things are often quite tight and swollen those first 6 to 8 weeks. Then kind of a lot of that's gone down. They've kind of settled a little bit. So that's what I tend to say. What about you?
The same. Yeah, it's going to take a while. It's about setting expectations. Initially, I say they're going to look pretty swollen, pretty large the first week or so, just because it's surgery, it's a trauma. And then I still feel like even in similar to a breast augmentation, there's this drop and fluff phenomenon where the swelling goes down, they sort of droop, and then they rebound as the months go by. And typically that 6-month, 1-year visit, patients are very happy, ecstatic. We're fine-tuning some scarring, encouraging, and reminding that patients, and ultimately scarring. There's multiple factors for that, including genetics and other things that you try to optimize as best as you can. But breast reductions tend to be very, very happy. I think I think it would be great to debunk some myths or answer some frequently asked questions. Maybe we can go back and forth by some very common questions that we get. One question is, can I still breastfeed after a breast reduction?
Yeah, that's a very common question, especially for younger patients. And again, like we talked about, the nipple being attached to an adequate pedicle of breast tissue, those ducts are still intact. I tell patients it's similar to the normal population, where 33% or so of patients try to breastfeed and are able to. 33% try and have difficulties, and 33% don't really try. So it tends to match up, assuming surgery, you write the right pedicle and surgery all goes smoothly. So that's all still connected, and your breast, that breast remaining breast volume will get larger when you get pregnant, and it then tends to get smaller after you're done breastfeeding. And what about the one where do people often ask you, will my breast grow back?
Yeah, I mean, everyone's really trying to hone in on what bra size they're going to get, or what's the breast size going to be. And for me, as we mentioned, other stores, it's hard to guarantee a bra size just because a C/D cup is different from store to store. But ultimately, it's their own tissue, so it will grow with them. So if they lose a lot of weight after a breast reduction, their breasts that we've reduced will also reduce. They will get smaller. And if they end up gaining a lot of weight, significant weight after breast reduction, the breasts are going to get larger. So it is a natural part of their process. And that's a great pre-op question that we both ask is, are they at a stable weight? Is this where they want to be? Because if they do plan or are anticipating weight loss that exceeds 15, 20 pounds or so, oftentimes I tell them to wait until they're at their goal weight or at their stable weight, because that's going to change the amount of tissue that we may need to remove, or the lasting results that are there.
Yeah, 100%.
A question about how painful a breast reduction is. I mean, you're cutting around the nipple, you're removing breast tissue. That sounds painful, but in reality, is it, Dan?
Yeah, I tend to rank this as one of the lower in the terms of the pain score surgeries I perform. Most people take pain meds for maybe 1 to 2, maybe 3 days, then ibuprofen, Tylenol. I think painful surgeries tend to be when we start messing with muscles, so abdominoplasties, tighten the muscles. If you're putting implants underneath the muscles, it's a little bit more painful, but still not that bad. Since it's all kind of soft tissue, they're sore, but most patients do quite well with this surgery. Would you agree?
For sure. Yeah, no, it's pain relieving in some instances.
Right.
And I usually, inform them that I anticipate after 2 to 3 days be taking Tylenol, ibuprofen, and they just recover better that way. Do you have a age range limitation, either too young, too old for breast reduction?
No, I mean, too young, the big thing is the breasts need to be stop developing. So you want to see stable breast size for at least a year, I think is what they typically recommend. So I've done 16-year-olds that have just really large breasts, kind of impeding their ability to kind of be part of high school sports and whatnot. But yeah, stability is really key for that. Older age really comes down to more just overall health. So most of the time when they're getting older, like, why didn't I do this 20 years ago? But they can still benefit from it, assuming they're healthy and can tolerate general anesthesia. I don't see any downsides to that for them.
Yeah, it's a wide range. I think everyone can benefit. They want to be mature, have thought about it for a while, know the risks and benefits, have realistic expectations, and could be freshmen in college, that I've performed surgery on in the past 6 months or so, to somebody in their late 70s who has always wanted it or feel like they're getting larger and need some relief from that. A common question I also get is, just how do you try to make them the right size? And I think what patients don't always know, or listeners, is that we're moving the bed. So we're sitting the bed up and down. We're actually using a ruler or measurements to make sure that the nipple distance from the fold is on, and comparing it to the other side. So it's not just like guesswork, or it's not just like we're putting some markings in pre-op and then we're just trying to figure it out. So there's a lot of math involved, and making sure that they're as even as possible. I don't know if there's any other tidbits or points that you point out as far as the surgical process of trying to make this a smooth surgery and recovery.
Yeah, I think, we really covered all of it, but when it comes to bra sizing, I ask what they want, and then I kind of look at their anatomy, and like, if it's really big change, like G to B, probably not going to get there. But I can guarantee you'll be lifted and proportional and a lot smaller, and then we can err on the smaller side, or you can err on the fuller side, depending on what those goals are. But dialing in a certain cup size can be much more challenging. Today, I had a patient come in. She's like, "Yeah, I haven't really figured out what bra size I'm in. 32 double D to a 36C." I'm like, "Well, that's actually the same size, because as you go up in band size, the cup size drops one. So 34D would have been kind of the in between, but all same actual breast volume." So that's just kind of some of the confusion with breast sizing that. And this various companies and how they all do it, that can make it so confusing. What else? Was there anything else to touch on? What about male breast reduction?
Yeah,
podcast.
Yeah, I think that's probably a separate podcast. Just know that men can have this surgery too. That requires a proper medical workup. But if there's extra breast tissue, extra skin laxity, either from weight loss, weight changes, or other factors, similar techniques can be done. Liposuction only, a minor incision around the nipple where some of the extra breast tissue can be pulled out, or actual removal of skin, breast tissue, fat with larger incisions. The only other thing I would say would just be hitting on a couple of most common issues post-op, or complications or problems. What are the risks to it? And I would say that for me, the large part, although patients are always are very happy, thrilled with the results, happy that they had it. The biggest issue for me is that the T points, there can be some incisional wound breakdown. I wouldn't say it's inevitable, but it's, you want to try to focus on that and minimize that, and always telling them up front that, there is pressure, there's limited in blood supply. We're bringing things together. We want to offload from where the bra sits, want to make sure the skin closes, and we're using surgical techniques to optimize that. But having a little penny dime-sized area that may open, that may require wound care, just with the amount of suturing and the amount of length of incision that we have, is not, a total surprise if it does happen. Constantly trying to improve and decrease that, but some of those are inevitable. Other than that, we've talked about nipple sensation, wound healing. What other key points do you mention to patients in the pre-op and peri-op area?
Yeah, I think that the T junction is kind of the big one that it's not inevitable, but you want to. It's the most common thing that might occur. Sensation, breastfeeding. When we go over consent forms, we hit on things that only happen less than even 1% of the time. So we talk about a lot of stuff, but fortunately, these tend to go very smoothly with very, very high satisfaction rates. So it's a very rewarding surgery.
There's no increase in breast cancer. If anything, there's a reduction because we're actually removing breast volume that's there. And post-surgical changes from breast reductions, breast lifts is easily, differentiated between something that's malignant or cancerous. And so I don't think that there's any additional risks in that category. So I think this was a pretty all-encompassing review of breast reductions, hit the common and some of the interesting when it comes to breast reductions, a very frequent surgery that we undergo and work with patients to deliver the results that they want. Yeah,
we definitely think we hit it all. So looking forward to doing some more of these. I think we have a couple more slated in a few weeks, but hopefully it just keeps getting warmer out and keep staying busy.
Great chat, Dan. Don't work too hard.
Great chat. It's been too long.
Yeah. Have a good one.
Talk soon.
Thanks so much for tuning into this week's episode of Fuller Butz, a behind-the-scenes plastic surgery podcast. Doctors Fuller and Butz are so appreciative of your time and attention. We invite you to subscribe, share, and continue to enjoy our plastic surgery perspective. Feel free to reach out on Instagram at either @FullerSurgeryMD or @DanielButzMD. That's Butz with a Z for comments, suggestions, and support. Remember, be artsy, stay scientific, and make life fun. We hope you'll join us again on the next episode of Fuller Butz.